Okay, gang, listen up. It is Saturday. It is Saturday morning. Gosh, let me tell you, these zebras, they kept me up late last night. So all I could do last night was say over and over again, I have to go make my slides. I have to go make my slides. I haven't made my slides yet. And already Marianne had made me feel so guilty because, I procrastinated. And they kept me up all night long, dancing and telling me stories and, all these things about, and I don't know why, but all they want to talk about is diarrhea all day long, all day long, all day long. It is very fortunate. I love diarrhea. Very fortunate. So my job today is to talk to you about something called a multidisciplinary team, right? The benefits of a multidisciplinary team. And I think what I'm going to do is just tell you very plainly and obvious things. That's what I'm going to do. Because I am not as smart as Dr. Metz or Dr. Burslin. I am not as skilled as Dr. Boudreau or Dr. Wang. But, I think about this a lot. And I really think about what is important and what is important to you guys for taking care of you. And one of the things that's really important is realizing that maybe I'm not as smart as everyone else. I don't know everything that Dr. Odorizio knows. I don't know everything that Dr. Warner knows. And so really, in order for me to look as good as I do, it takes a lot of work, let me tell you. I rely on a lot of people. So this is what I do for a living. I just rely on other people, and we think together, and we work together, and we hopefully find the best plan for you. All right, so sit back, relax, have a stiff drink. It's going to be a long one. Let me introduce you to my friend. This is Susie. For those of you in the audience named Susie, you should wear a red dress tonight. It would be really great. Susie has developed a stomachache. And you can tell me if this sounds familiar. She's developed a stomachache. Kind of comes and goes, it's not really bad. And then one day it is really bad, right? It's really bad. So Susie, she makes her way to the emergency room, right? Emergency room drops her off in the radiology suite because they really have no idea what's going on. Oh, you got a tumor, got to go to the surgeon. I'm sorry, so you go to the surgeon. Oh, surgeon takes it out. Oh, you better stop by at the pathology. Just make sure you pick that up. Oh, gosh, you have neuroendocrine. You better go to the oncologist. So you go to the oncologist. The oncologist does all these scans, sends you back to radiology. Oh, you need to go to nuclear medicine because you need this special scan because it might be something called neuroendocrine. You're like, what is that? And by the way, you need a big old shot once a month in your derriere, so you see the nurse. And you're getting all these labs because the nurse just heard about Mia talking. And then your stomach hurts from the shot, right? So you see Janet. And then, gosh, your breathing is not so perfect, so you see the pulmonologist, and they can work on things. And then you're just crazy, so you can't sleep, so you go see the sleep specialist, right? And then, you're not feeling so well, your sugars are off, you see the endocrinologist. Oh, it turns out you have liver metastases, you go to the interventional radiologist. And let's see what Susie does, right? She's been walking around all this time, and all she wants to do is get off of the slide, right? It's all she wants to do. So has anyone felt or experienced this in the room? Right, so deep down inside, we're all Susie, right? And this is a problem. This is a problem, right? Because you're home, right? These doctors are not on the same place. Some are at the hospital, some have private offices. You go from one, you go to the other. You can't really figure out what's going on. And that's, I think, as you see, is a very, very common story. And it can probably be replicated about 100 to 200,000 times. So it was very important, we as kind of neuroendocrine people, to say this is something that's important. We understand that it is extremely, extremely frustrating for you all to go through this process. Right? So when the good Dr. Coles, many years ago, in 2006 or 2007, developed this society called the North American Neuroendocrine Tumor Society, which is kind of the doctor society, the professional society. I think it was in 2006. They really felt it was important that we do something for you, right? And so in their guidelines, they wrote pretty explicitly that there must be evidence-based treatments with an emphasis on multidisciplinary team-based approach to patient care. Right? So I'm not making this up, right? This is very much what you live. This is very much what people recognize, right? And don't get me wrong, I have been accused of making stuff up all the time, right? So my wife says, "Did you eat all that chocolate ice cream?" I say, "No, honey, I had clinic. This is all diarrhea on my face." Don't worry, it was chocolate ice cream. I ate it all. I ate it all. I know. Anyway, so look, so this is recognized by you. This is recognized by the physician, so it's very important. So it's important. There's a rationale behind all this. And so I turn to, much older doctors. His name is Dr. David Metz, much older than I am. He's right there. And so I asked him, I said, what, I want to do this, right? I think multidisciplinary is very important. So I looked to his writings and his teachings. And he says basically that it's very important to have a multidisciplinary team. It's very, very important. I say, okay, why? Well, here are the goals. This is what you want to do, right? This is not fancy. I told you, I'm really not that smart. This is what you want to do. You want to reduce the amount of morbidity and mortality to you, right? Because no one wants to have complications from a bad decision. And you want to live longer, okay? You certainly want to, we as professionals and hospitals want to improve your patient satisfaction, your quality of life, okay? And I might disagree a little bit with this because I think quality of life is extremely important. But there are a lot of people involved in figuring out how to make your life better, right? Certainly we need to enhance coordination of services. Has anyone in this room ever said, just felt like they were being tossed around from place to place because it was totally uncoordinated? It's very, very, very common. Very common. It's like calling Comcast. You provide... But we want to do this, right? We want to do this right. We want to do this based on evidence, things that we've thought about, things that people have tested, right? So as much as we possibly can, as much as we can evaluate the information we have, because neuroendocrine is a relatively small field, right? It's growing, and the community is growing, but it is a relatively small field. So we don't have the same kind of information that we have on breast cancer or colon cancer or prostate cancer, which are the probably three most, lung cancer, which are the most common, right? And certainly we want to provide an easy and efficient way for you to access those evidence-based treatments. And, if you can, it would be terrific to reduce costs, right? Because it is a turbulent and changing time in healthcare. And so those are all the things that we want to do as a team, right? And if that means just getting 12 or 15 people in the room together, that seems really easy. You know what? That is really, really hard. It is really, really hard to get 12 people from different specialties with different schedules and different clinics to show up at the same time, right? You know what's the common time that everyone's free? 3:30 in the morning. Yeah. We can't do 3:30 in the morning. So you know what some people do? They do 6:30 in the morning, right? 6:30 in the morning. Very, very common, right? Radiologists do not like to come in at 6:30 in the morning. They really don't. So sometimes we try to do 7, or the pathologists too, right, exactly. So, sometimes we do noon. And then sometimes people get late and they can't show up. I'm just telling you the truth, right, from the other side, so you understand. But we try our very, very best, which is why when you go to some place that specializes in this, who really believe in this, we try particularly hard. All right, so let me just tell you a little bit about what a multidisciplinary team is, so you get a sense of what I'm talking about, right? So this is not, so at least the terminology is clear. I'll tell you about the members of at least what I think and Dr. Metz thinks are the members of the team. And then I'll tell you a little bit about how I think they should all work together, right? How they should talk. And then something interesting, which is, do others value a multidisciplinary team, right? Because I'm sure some of you have gone to doctors, oh, you don't need to see a specialist. Oh, we can take care of these things, right? So not uncommon. And then the question for you is, how do I know if I'm being cared for by a multidisciplinary team? Right? It's kind of like saying, well, how do I know I have a good auto mechanic? It's not so easy once you kind of really think about it. And there's no great data on this, so I'm up here and I'm going to rant and rave, basically. I'm going to tell you what I think, and you guys can take what you want from it. But this is basically how we function, I think, as a community of physicians. So what is a multidisciplinary team? Well, it's really a bunch of docs and nurses and specialists who specialize in healthcare, and they get together around a table with a big screen, and they talk. And they talk about you, right? So rather than getting just that one appointment, at least you thought it was just one appointment for 15 or 25 minutes, you actually get a little bit more than you think. People get together, they talk, they think, they look at your pictures together, they bounce ideas off of each other. And they have to come from different specialties, right? Because you don't want, just 10 oncologists talking to each other, because then you're just going to talk about the same thing over and over again. You don't expand the box of thought, right? And really what you need is a group of people who are experienced in the needs of neuroendocrine patients, right? Because your needs are different, right? So there was a question about, well, the patient has diarrhea, but then you think, well, what are the causes of the diarrhea? Is it from their surgery? Is it from their hormone? Is it from the treatment that we're giving and the lack of pancreas function, right? And these people really need to be dedicated to the care of neuroendocrine, right? That's really what it is. You identify someone, they're the champion, and then they bring people who are like-minded, like, for example, Dr. Shi, right? Yesterday, you heard her talk, and she showed you all those slides. And she is a brilliant woman who came from Johns Hopkins when she finished training to come work with me. And because we're so like-minded, we can work together and make a lot of progress, right? So that's really very important. And what we do is we talk. We talk. And by talking about it, we think more about it, and we can hopefully arrive at the very, very best treatment plan for you, whether it's at our center or you work with someone else at another center, or you send them to Europe, which is not uncommon for a lot of the patients in this room and for us as professionals. So that's what a multidisciplinary team does, okay? It's a bunch of people who think about you, who bring a lot to the table. All right. So who are the members of the team, right? They're actually a whole bunch of people, which is why it's hard to get them all in the same room at one time. Certainly, usually, at least in the United States, the person who controls it most often is the oncologist, right? Because you enter through their office most of the time. And then, of course, the surgeon, the neuroendocrine surgeon, surgical oncologist is extremely important. Then you have all these other people, lots of other people, endocrinologists, gastroenterologists, the pathologist shows the slides to explain the path report. The radiologist goes through the scans beforehand and shows it to you, because despite the fact I've met many of you this weekend, and you bring me reports, and what do I keep telling you? It's tough, I really need your disc, right? So we sit together and we look at the pictures. The nuclear medicine physician, who's actually different from the radiologist in specialty places. Sometimes they're the same at smaller hospitals, but they're different at big places, because they not only look at the scans on different machines, but they can offer you different therapies. Then for bronchials, which I have an interest in, the pulmonologist is there, the thoracic surgeon. Sometimes when your liver is in bad shape, the interventional radiologist be there. The psychiatrists, it would be terrific. And then, of course, nursing and nutritionists, geneticists, and even a librarian we work with. So this is what they do, right? So the oncologist actually has a more kind of broad role usually. They're usually the captain of the ship. But they give chemo, and they usually follow up on the patient and screen them, right? The surgeon obviously does surgery. It's not fancy. The endocrinologist does a lot of things, right? So if there's a genetic component to it, which we'll hear about later today, you usually want to have an endocrinologist who has an interest in that type of thing. Testing for hormones is very complicated, as Mia taught us yesterday. And so you want to know which ones to draw. And there are 1,000 different tests, and it's choosing the right tests, right? The gastroenterologist is extremely important, because lots and lots of people have GI problems, right? So they need to be scoped. They need to have their ultrasound done. They need to have care for their abdominal pain and their diarrhea, and sometimes they can help with that. The pathologist will look at the specimen, they'll bring it in, they'll specify things, they'll tell you, oh, the Ki-67 is actually hot in this spot, but maybe colder in this spot, and different in this tumor and that tumor. And as we mentioned yesterday, and poor Dr. Shi, sometimes I'll dig out 25 tumors out of a patient, and then she'll have to go and cut every single one of them, right? So I torture her. It's a good thing she loves me. And then the radiologist puts up the scans, right? And the scans aren't so simple, right? Because sometimes they get CT scans, and sometimes they're imported from the outside, and sometimes they don't load up, and maybe you need an MRI, and an MRI is a very complicated scan to read. There are actually like 15 or 25 different series of pictures that they have to go through in order to find the right measurement for you, which may be a tumor measurement, it may be detecting new disease, it may be finding disease elsewhere that you didn't look at. Let's say you and I are in clinic together, and I look at your liver, and we don't have a report yet, and then the radiologist says, oh, by the way, there are tumors in your spine, right? That happens. Then the nuclear physician, he or she brings in your Arcturus scan or your PET scan. Why is that important? Because they have a special machine that only shows the Arcturus scans and the PET scans, right? And it's not available in every single room in the hospital. And of course, the primary care physician is very important. We often forget about that because people with neuroendocrine can have other problems, right? You still need your mammogram, you still need your colonoscopy because you live so long, you do so well. We want you to do well. Your hypertension may need control, your diabetes may need control, and sometimes you get head colds, right? So everyone plays a very important role. The pulmonologist, obviously, for breathing. Lots of people in this room have a bronchial. We don't always talk about bronchial so much, but the wheezing, the breathing, the coughing, those are very important things. You have to rule out kind of basic stuff and help make sure we can treat it with the things we have. Of course, the thoracic surgeon to cut it out. When your liver is heavily involved, right, the interventional radiologist has to come. The psychiatrist, for many, many reasons, should probably be in the room. The nursing to help coordinate things, and of course the nutritionist who can provide specialty kind of thoughts about nutrition, especially for neuroendocrine. It's very, very important. And then of course the geneticist to help with the endocrinologist if there's a genetic, familial portion of it. And of course we happen to work with a librarian because the information is becoming more and more complex. And keeping track of all the information is actually a full-time job. So these are the people who can kind of contribute to a neuroendocrine team. And it changes over time. It changes, right? So if you are diagnosed relatively early, these are the people who are going to be involved in your care, right? It's going to be mostly probably the endocrinologist through whose office you may come through, the surgeon, the gastroenterologist, and the pathologist to kind of figure out what's going on, right? And of course, these people are floating around the team or the hospital to help you because they're gonna make a huge impact. Maybe the benefits manager is the most important person for you at the very beginning because you can't figure out whether or not, what's happening, you're blindsided, and guess what? You also have a huge bill to pay, right? It's not so simple. Then when the disease kind of lingers on and you're getting better care and you understand things, the team changes, right, in importance. So in late stage development, the oncologist may have to do a little more for you, and then maybe if there's heart disease, as we learned yesterday, the cardiologist will be involved. If the liver is getting very complicated, the interventional radiologist and the surgeon, right? The surgeon actually never leaves because we have very effective methods of diagnosing and caring for things, not just trying to cure you, but also trying to improve your quality of life, rewiring your intestines, making sure your food doesn't get stuck, making sure we get out as much tumor as we can so your endocrine load isn't so high. I mean, these are all things we learned about yesterday. And you see, never do any of these people go away because you have to go back and forth, because you need more and more help. And that's basically how it works. Okay. So how do they work together, right? At least this is how I think they should all work together. Well, essentially what it is people have a complementary skill set, right? I mean, it's the same thing in business, it's the same thing at home, it's the same thing at school. And with that complementary knowledge and skill set, you want to work with each other, right? Because ultimately, it is very, very difficult to remember everything about everything. And I kind of, since I trained in Europe, I kind of fancy myself like a neuroendocrinologist, right? In the sense that I was trained as a surgeon, obviously, that's what I do for a living. But I think very, very hard, at least in the neuroendocrine world, I think very, very hard about the hormones. I think very, very hard about the imaging. I think really hard about the chemo. And by hanging around those smart people like Dr. Bergslin and Dr. Wallen and Dr. Fisher and those kind of people, I learned a lot. In fact, I'm hoping to learn even more because the Neuroendocrine Tumor Society meeting is going to be in Nashville in October. And so I do that on purpose so I don't have to travel so far so I can think about all the things that they're going to teach me. Right? It's very important. So, but it's hard to keep, I know it's hard to keep all that in order because there are details, very fine details about things. And then sometimes there are multiple treatment plans, right? So one of the things we discovered is that there is no right, one of the problems we have in neuroendocrine is that there's no right answer. Right? So sometimes you can be lulled into a sense of security because your disease is slow. Some people may advocate very, very, very aggressive surgery. Some people will not advocate. You want to watch and wait, right? So I can't tell you exactly what's right. So we have to think really hard and bounce it off other people. And sometimes having different eyes on the same patient helps a lot. Because if I see a patient and then Dr. Boudreau sees a patient, Dr. Waltering sees a patient, and we get our minds together, we may learn different things about that patient. and then come up with an even better plan. And sometimes when you have very, very difficult cases, you need that validation and reassurance, right? I have certainly called this gentleman here for help. I've called Dr. Granberg and Dr. Oberg on many occasions for help, because I just need to think about, all the things that are involved, and they have much more experience than I do. So I ask them, and that's what I do. So when you think about the individual input, there's actually a lot of it if you kind of break it down. So let's say you see the neuroendocrine specialist. You see Dr. Warner, right? So he figures out, he talks to you, you get a history, a physical, you get this pattern disease and a diagnosis, hopefully. He figures out what imaging tests you need, right? And I should tell you a story. So, we were very fortunate at where I used to work at Vanderbilt to be the very first people in the United States to do this gallium scan, right, in people. Do you know why I started doing that? Because Dr. Warner called me and said, hey, I've got this patient, do you think you can help me out? And so because of this kind of across the country collaboration, because he knew me, he knew I had an interest in imaging, we worked this thing out, and she became the very first person to ever have a gallium scan. So that's very important. And then the lab testing is extremely important, as we learned about. You'll arrive at a diagnosis, and a lot of people see neuroendocrine specialists just to understand the disease, right? How many of these people, a lot of you have come to me, right? We sat for an hour, you come from a long distance, sat for an hour, and all I didn't do anything for you except hold your hand and explain your disease to you, right? Was it valuable to you? It was, right? So even just that communication is extremely important. And then, of course, developing a follow-up plan wherever you go home. Now, the surgeon may have different roles, right? He or she may just have to explain the operation to you, which is important. There are risks and benefits to every operation, and there are special considerations for neuroendocrine, right? How we do the operation, how we debulk, and things like that. The radiologist, the nuclear medicine physician, will actually review the scans very carefully in preparation for the tumor board meeting. They'll do a complete analysis of the image data, so that may mean scans from 3, 4, 5 years ago, right? We talk about a slowly growing disease. Sometimes you don't have progression over 3 months. Sometimes you don't have progression over 6 months because it's too small. But guess what? Over 3 years, it's maybe gone from 4 centimeters to 12 centimeters. It's an exaggeration, but that's what you see. That's kind of how it works. So they analyze all that. They show you your Arctria scan and the PET scan on this specialized equipment because it doesn't always show up. I get these discs, right? You bring me these discs with an Arctria scan. And what are they? You know what they are? They're JPEGs. They're screenshots from their machine, and then we have to make decisions on it. So it's complicated, which is why it's nice to have them in the room. And of course, if you need a nuclear therapy, then the nuclear physician needs to recommend that because that's what they control, especially in Europe. The interventional oncologist brings a lot of information too. They can tell you the type of therapy to have. Maybe you don't need Surspheres, or maybe you do. Maybe you need Theraspheres, or maybe you need a bland embolization because the tumor is too big and the radioembolization is not strong enough. Or maybe there's a problem with your anatomy, right? Because they look carefully at your scans. And then they get you scheduled because that's actually not so easy. Getting a radioembolization is very expensive. And so it requires this this insurance pre-authorization. So these things are very important, and the devil is in the details. The pathologist obviously brings in the type of tumor. They can tell you about the features of the tumor, the mitoses, the Ki-67, the staging, things like that. And of course, the medical oncologist has a lot of information. What type of therapy do you do? Do you start with hormonal therapy? Do you give the targeted therapy? Do you give the chemotherapy? Each one of those has a different risk and benefit profile. So he or she has to explain that to the team, and needs to explain and educate us and tell you. What are the risks and benefits? And what are the goals of the therapy, right? So there are some therapies in which all you want to do is maintain stabilization, which is terrific, right? And I'm sure a lot of you in this room have stable disease, and everyone's happy about that. Because every day you can live without any side effects from your therapy is a day you live well and have a good life, right? So what are the goals of therapy? And then, of course, the endocrinologist is very important because that hormonal control can be difficult, and you may need other tools in order to put it all together. You may need to increase the dose beyond what's recommended by the company and the FDA. And so those specialty things are really what you need from the people who bring this information to the table. So let's say you don't have a multidisciplinary team, right? So you're at your small hospital with your local doctor in New York City, let's say. And despite the fact that New York has a lot of people, sometimes it's hard for them to talk to each other, right? So it's not so simple. Then this is what they go on. They go on some report, right? Because they don't always have the availability of the scans. They don't always have the disc. They don't always have that information. and you read 2 foci of increased uptake within the liver. You don't really know where it is. You don't know if as a surgeon, I don't know, is it next to the portal vein? Is it next to the hepatic vein? Am I going to cut something? Is it going to be a chip shot? Can I do it laparoscopically? Do I have to do it open? So there are a lot of these details which I can't figure out. Look at the pathology, right? So the pathologist says, this is actually a pretty good one. So we had asked, what is the Ki-67? What are the mitotic figures? There's nothing in there about hotspots, right? There's nothing in there about lesions in segment 4 or 5 or 6, right? So those are all very important things. And so when you sit around the table, you can talk about it. You can ask questions. You can probe. And then they can answer that question back for you. Okay, so this is probably what it feels like for you. Poor Susie. She works so hard for us. So, and you feel like you want good care, you feel like you're kind of on the cusp, you're bouncing up and down, and then at some point you're just like, I can't figure it out. Why? Okay. Because there are a lot of silos, right? This is what we talk about, silos. People live in their own little kingdoms, right? So you start with the surgery, you start with, you have the primary care physician, you have the gastroenterologist, you have the oncologist, you have the endocrinologist. I'm saying the same thing over and over again, pulmonary, cardiology. And sometimes you just need a net specialist to help you put it together, right? And so the question is, do others value a multidisciplinary team? I know for sure that most of the community docs all around the country, right, which is why we started this work, really know the limitations of their disease with you, right? Not all of them, but most of them do. And so they really appreciate the input from the various specialty centers, right? And so knowing that they can't pull all these people together, they rely on these centers of specialty in order to answer their questions. So I think the answer is yes. I think most people would value that. Now, I should clarify just a little bit. A neuroendocrine multidisciplinary team is probably a little bit different from just a straight old tumor board, right? You may have heard of tumor board before, right? That's essentially where all the cancer people get together and they talk about, how do we treat this patient? What clinical trial do they go on? And they move on. Well, a multidisciplinary team, as you can see here, is actually more complicated for you guys because you guys have so many more issues, right? So some of my nurses complain that all my patients are very high maintenance. And there's some truth to that. There is some truth, right? I mean, you have to admit it because there's just so many issues that it gets very complicated. And that's why it can be so difficult because you're frustrated. You may have been frustrated for 5 to 7 years trying to get at a diagnosis. And here you are finally trying to get some answers, right? So this, I sympathize. I completely understand. So it's very, very important to have that multidisciplinary team together to talk about all these various things for you. And if you're lucky, you go to a clinic, you can see multiple people, maybe even on the same day. Right? So here, how do I know? How do you know if you have a multidisciplinary team? Right? Well, in general, you should have a core team, right? And there's usually some kind of coordinating physician, right? And this is not always well defined, but usually it's either your surgeon or your oncologist, right? So you have a core team. So at least people know that. And then the function of that multidisciplinary team is to see if you can have this one-stop shopping, this one-stop visit, right? So you can usually tell if you can sense that as you see a nurse, a nutritionist, a doctor, a surgeon, and they work these things through. But it's not perfect. It's not perfect. And you may go to a very, very famous center because of the reputation, but if they don't really specialize in neuroendocrine, they may not have a true kind of multidisciplinary approach or even philosophy to it, right? And that's why it's so important. So now here's poor Susie, right? Bouncing around from place to place to place, right? Specialists. And then sometimes what happens is she gets stuck in the silos and she falls through, right? But what we do is, since you have a multidisciplinary neuroendocrine team, we can catch her, right? So we can support her because now everyone's working together, holding the net together to really make sure that her needs are met. And that's really that's why it's so important. You see it over and over and over and over again in all the written things, in all the lectures we present, because it is true and it helps you. Right? Now, it's not so simple, right? Because you don't know if you have a multidisciplinary team. So sometimes that coordinating physician, that coordinating person is you, right? So a lot of you walk into my office and you have this huge binder of information. You bring this whole file of scans, and I have to sit there and read through them and get through it, right? Because you're doing your job. You're doing your job because you now understand the disease perhaps better than your local physician, and you are kind of coordinating that. So you actually become the core of that neuroendocrine team, of that multidisciplinary team. And it is not easy, right? And I don't blame the university sometimes having now understood it. It's because sometimes when you want to do new things and you want to try new stuff because what's currently happening is not adequate, can either be facilitated or impeded by the institution. So despite the fact that everyone wants to do it, it's not easy. And so I don't ever blame anyone for either not having the team together or not having enough of the team together, because it's very, very tricky. And so we just have to understand that there are strengths to it, there are benefits to having this kind of structure, but it's not always practical, right? So what can you do as a patient? I think what you can do is do things like this. You can be here, you can educate yourself, right? A lot of you get on the internet, you absorb as much information as possible, you get on the social media, right? You talk to each other, you learn from what other people's experiences are, and you educate yourself because now you have to become the expert. But it's not fair to you. It is not fair to you to have to do all these things because there's so many details and so much context that you will never ever get from WebMD or even the NIH site, right? So what you have to do is you have to ask a whole bunch of questions, right? So you have to be empowered because you are the core and the center of that multidisciplinary team. And you get to keep detailed records, right? And if someone is not happy with the fact that you're asking questions and bringing a whole binder to you, you may just want to think about what that person brings to your table and to your team, right? I say this a lot, and I really mean it, but I really think you should find a net specialist. It certainly doesn't have to be me. It can certainly be any of the people in this and the specialists in this room. I've calculated, and there's about 573 years of experience in this room, right? I was about to say 350 years come from Dr. Warner. But find someone, because we talk, we work together. We're actually very, very good friends. I mean, really, really, we are very, very, we don't always agree. We don't always agree, but we are good friends and we believe in each other, right? Commune with your other patients, right? I mean, this is what we do. This is what you are doing right now. Actually, it was fun being out so late last night, because I never do it because I have 3 young children. But it is really fun because you hear about things and people's experiences and the good things and the bad. And sometimes you want to embrace and relish the good things. And I look around this room, and I know a lot of people in this room, and I'm so delighted that you're here and healthy and doing the things that you want to do. Keep a positive spirit, all right? Because it can be very frustrating when your local guy doesn't know exactly what's happening, or you have a bad biopsy, or you have a bad read on your scan, or the scan is done incorrectly. I'm telling you things that I think everyone's experienced, right? So don't be frustrated. Just understand this is how the system works. So always be positive about it. Learn, 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 learn. And remember, each one of you is a warrior in this crusade, okay? You are very fortunate to have field generals like Dr. Boudreau. But each one of you has to get out there and spread the word and do what you can and work with the organizations and work with the Waymans and work with the foundations so that people can understand. Because if you're doing well, right, there is going to be someone who is a little confused and scared out there. And by giving back to them, you can significantly change their lives, right? We have to do this together. Otherwise, we'll always be an orphan rare disease, despite the fact there are like 250,000 of you walking around. So let me just tell you something. This is how I feel. Essentially, everything you do should be based on 2 major tenets. One, this is not about me, right? This is about you, right? So everything that you do should be about you, about your care, about your understanding, about your education, and about your quality of life, right? My ego doesn't get into it. Despite the fact my wife tells me my head is gigantic, it doesn't fit on my head, my neck, it is about you. It is about you. It should always be about you. And if you don't believe that, start, all right? And you need to do that. And second, I feel it's about your quality of life, right? I can't always affect your quantity of life. I try as hard as I possibly can, but I can't always affect that. But what I can do almost all the time is improve your quality of life, right? So I promise you that this is how we all feel. We're going to help you feel better, get to a point where you're doing the things you want to do, so you can be with your children, your grandchildren, your loved ones and family, so you can travel. You can travel to Charlotte, and you can learn, you can be with people. This is what we want to do. So that quality of life, that quantity of life, are in that order, are very important. And I think if you keep these two very fundamental basic tenets in your mind and in your heart, you'll be happy with things. Does it stink to have stage 4 cancer? Yeah, it stinks to have stage 4 cancer. Does it stink that you're like 33 years old and you have no idea and the emergency room doctor told you, oh, you've got 3 months to live? Yeah, it stinks. But it doesn't have to be that way, right? And when you work with the right people, you get your team together and they can talk to you and work with you and do the things that you need, you can achieve this. So thank you very much. I think we're a little ahead of time, but these are the people who I think, and who I don't have a sign, but look at the Swedes hanging out with me in Nashville in a honky-tonk. They're a little uptight, but they can have a good time. Right? Of course, Bob and Marianne have been very important to me. Dr. Granberg, my dear friend, is here all the way from Sweden for about 48 hours. So for those of you who are interested in bronchial, we invite you tomorrow to, I know it's not in the pamphlet, but we have a special, very important special session tomorrow morning about neuroendocrine in the lungs. Because despite the fact you occupy 25% of the space, you only occupy probably about 3% of the talks, right? And this, unfortunately, was the team that I was working with, but they are wonderful, wonderful people. Dr. Shi, my favorite. And here are my dear friends, Dr. Oberg and Dr. Ackerstrom. We were sitting together on a Mediterranean island. It's a little bit better than Charlotte. But this certainly was a lot of fun. So thank you very much for your attention.